This talk is about pulmonary edema. To pulmonary edema. Pulmonary edema results from excessive amounts of fluid movement to the extravascular system and the air spaces of the lungs. Fluid first seeps into the paravascular and parabronchial interstitial spaces, and depending on the degree of severity, fluid may progressively move into the alveoli, bronchioles, or even bronchi. As a consequence of this fluid movement, the alveolar walls and interstitial spaces swell. As swelling intensifies, the alveolar surface tension increases and causes alveolar shrinkage and atelectasis. Moreover, much of the fluid that accumulates in the tracheobronchial tree is churned into a frothy white or sometimes blood-tinged or pink sputum, and as a result of air moving in and out of the lungs, the abundance of fluid in the interstitial spaces causes the lymphatic vessels to widen and the lymph flow to increase. Pulmonary edema produces a restrictive pulmonary disorder. The major pathologic or structural changes of the lungs associated with pulmonary edema are interstitial edema, alveolar flooding, increased surface tension of alveolar fluids, alveolar shrinkage and atelectasis, and frothy white or pink secretions throughout the tracheobronchial tree. Remember that when you have interstitial edema, there is also fluid engorgement of the paravascular and parabronchial spaces and the alveolar wall interstitium. This shows pulmonary edema. It's a cross-sectional view of the alveoli, showing the alveolar duct in pulmonary edema. You can see frothy white secretions, interstitial edema, as well as red blood cells, and atelectasis in the inset. Atelectasis is a common secondary anatomic alteration of the lungs. According to the American Heart Association, Heart Disease and Stroke Statistic Update, heart disease, including coronary heart disease, hypertension, and stroke, remains the #1 cause of death in the U.S. Coronary heart disease in 7 deaths in the U.S., killing over 300,000 people a year. The overall prevalence for an MI or heart attack in the U.S. is about 7.9 million, or 3% in U.S. adults. In 2015, heart attacks claimed more than 100,000 lives in the United States. The estimated annual incidence of heart attacks in the United States is about 720,000 new heart attacks and 335,000 recurrent heart attacks. The average age of the first heart attack is 65.6 years for males and 72 years for females. Approximately every 40 seconds, an American will have a heart attack. From 2005 to 2015, the annual death rate attributable to coronary heart disease declined almost 35%, and the actual number of deaths declined over 17%. However, the burden and risk factors remain alarmingly high. The estimated direct and indirect costs of heart disease in 2013 to 2014 was over $200 billion. Heart attacks cost the American public over $12 billion for that year. Coronary heart disease cost $9 billion and were 2 of the 10 most expensive conditions treated in U.S. hospitals. It is projected that between 2013 and 2030, medical costs for coronary heart disease are going to increase by 100%. That means that for heart disease, we will spend billions of dollars on heart disease. Cardiac pulmonary edema occurs when the left ventricle is unable to pump a sufficient amount of blood during each ventricular contraction. The ability of the left ventricle to pump blood can be determined by means of a left ventricular ejection fraction, or LFEF, with a non-invasive cardiac imaging procedure called an echocardiogram, or echo. This reflects the patient's left ventricular systolic cardiac contractility. Poor ventricular function may also be caused by increased ventricular stiffness or impaired myocardial relaxation. This condition is called diastolic dysfunction and is associated with a relatively normal LVEF. Normal values for the LVEF range between 55% and 70%. An LVEF of less than 40% may confirm heart failure. An LVEF of less than 35% is life-threatening, and cardiac arrhythmias are likely. The most common cause of left-sided heart failure is congestive heart failure. This occurs when the left ventricle is unable to pump out a sufficient amount of blood during each ventricular contraction. This is determined by means of a left ventricular ejection fraction, which can be seen on an echocardiogram. This reflects the patient's left ventricular systolic cardiac contractility. Normal values for left ventricular ejection fraction range between 55 and 70%. A left ventricular ejection fraction of less than 40% may confirm heart failure. A left ventricular ejection fraction of less than 35% are life-threatening, and cardiac arrhythmias are likely. When a left ventricular ejection fraction is low, blood pressure inside the pulmonary veins and capillaries increases as a result. This action causes fluid to be pushed through the capillary walls and into the alveoli. Ordinarily, hydrostatic pressure of about 10 to 15 millimeters of mercury tends to move fluid out of the pulmonary capillaries and into the interstitial space. This force is normally offset by colloid osmotic forces of about 25 to 30 millimeters of mercury that tend to keep fluid in the pulmonary capillaries. The colloid osmotic pressure is referred to as oncotic pressure and is produced by the albumin and the globin in the blood. The stability of the fluid within the pulmonary capillaries is determined by the balance between the hydrostatic and oncotic pressures. This relationship is also maintains the fluid stability in the interstitial compartments of the lungs. Let's look at a few common causes of cardiogenic pulmonary edema. Arrhythmias, pulmonary embolus, systemic hypertension, congenital heart effects, excessive fluid administration, left ventricular failure, mitral or aortic valve disease, myocardial infarction, cardiac tamponade, renal failure, rheumatic heart disease, and cardiomyopathies. Many times cardiomyopathies may be viral in nature. Risk factors for coronary heart disease. Age. Males older than 45 years and females older than 55 years. Family history of coronary heart disease. A male relative with coronary heart disease less than 55 years old. A female relative with coronary heart disease and she's less than 65 years old. Smoking cigarettes. Obesity, hypertension, a high level of LDL-C greater than 130 milligrams per deciliter. This is the bad cholesterol. A low level of HDL-C of less than 35 milligrams per deciliter, the good cholesterol. A high level of homocysteine, less than 10 milligrams per deciliter, a total cholesterol level of greater than 150 to 200 milligrams per deciliter, and a high triglyceride level of greater than 200 to 300 milligrams per deciliter, diabetes, and obstructive sleep apnea. Now we'll talk about non-cardiogenic pulmonary edema. This is less common, however, and develops as a result of damage to the lungs. It can develop as a result of increased capillary permeability from alveolar hypoxemia, acute respiratory distress syndrome, or ARDS, inhalation of toxic agents, pulmonary infections, therapeutic radiation of the lungs, or acute head injury. Lymphatic insufficiency. Should the normal lymphatic drainage to the lungs be decreased, intravascular and extravascular fluid can begin to pool and pulmonary edema can occur. Lymphatic drainage may be slow because of obliteration or distortion of lymphatic vessels. These lymphatic vessels may be obstructed by tumor cells. They can also empty into veins and increase systemic venous pressure and may slow lymphatic drainage. Lymphatic insufficiency may also be observed after lung transplantation. Decreased interpleural pressure. Decreased interpleural pressure may cause pulmonary edema. With severe airway obstruction, the negative intrapulmonary pressure exerted by the patient during inspiration may create a suction effect on the pulmonary capillaries and cause fluid to move into the alveoli. Also, the increased negative intrapleural pressure promotes filling of the right side of the heart and hinders blood flow in the left side of the heart. This condition may cause pooling of the blood in the lungs and subsequently elevate hydrostatic pressure and pulmonary edema. A related kind of pulmonary edema is created by the sudden removal of a pleural effusion. Clinically, this condition is called a decompression pulmonary edema. HAP, or high-altitude pulmonary edema, can occur in people who exercise at altitudes above 8,000 feet without having first acclimated to high altitudes. HAP often occurs with recreational hikers and skiers. Decreased oncotic pressure. Although this condition is rare, if onc is reduced from the normal 25 to 30 millimeters of mercury and falls below a patient's normal hydrostatic pressure of 10 to 15 millimeters of mercury, fluid can begin to seep into the interstitial and air spaces of the lungs. Decreased oncotic pressure may be caused by overtransfusion or rapid transfusion of hypotonic solutions, uremia, hypoproteinemia or severe malnutrition, acute nephritis, polynephritis, and polyarteritis nodosa. Although the exact mechanisms are not known, there are other causes and conditions associated with non-cardiogenic pulmonary edema. Other causes of non-cardiogenic pulmonary edema include allergic reaction to drugs, excessive sodium consumption, drug overdose, such as morphine, heroin, amphetamines, cocaine, antituberculosis agents, and chemotherapy drugs. Metal poisoning, such as cobalt, iron, or lead, chronic alcohol ingestion, aspiration, central nervous system overstimulation, and encephalitis. Other causes also of non-cardiogenic pulmonary edema include high altitude, exercising at high altitudes, greater than 8,000 to 10,000 feet, a pulmonary embolism, eclampsia, and transfusion-related acute lung injury. So what will you see with pulmonary edema at the bedside? Some of the clinical manifestations that are caused by or activated by pulmonary edema are atelectasis, increased alveolar capillary membrane thickness, and excessive bronchial secretions, especially pink frothy secretions. Increased respiratory rate, heart rate, and blood pressure. Cheyne-Stokes respirations, paroxysmal nocturnal dyspnea and orthopnea, cyanosis, frothy and pink secretions, possibly a increased tactile and vocal fremitus, crackles, fine crackles, and wheezing. The pulmonary function test findings, if you have them, are a restrictive lung pathology. The lung volume or capacity findings are also a restrictive lung pathophysiology. Arterial blood gases in moderate pulmonary edema show the patient working really hard to breathe and blowing down their CO2. You'll find that the pH has gone up, the PaCO2 has gone down from working so hard to breathe in such a rapid respiratory rate. The bicarb is still normal. It hasn't had a chance to change, so it's still within the normal range, but probably low. And the PaO2 and SaO2 may be low. However, when you have a very severe person in severe pulmonary edema, you may have acute respiratory acidosis with a pH that has dropped significantly, a very high CO2. The bicarb may still not have had a chance to change, depending on how long the person has had the condition, and a very diminished PaO2 and SaO2. A true emergency. Oxygen indices are reflective of this. Abnormal lab tests and procedures. A low serum potassium, a low serum sodium, a low serum chloride, and an elevated BNP. The brain natriuretic peptide, or BNP, is also known as a B-type natriuretic peptide or ventricular natriuretic peptide. Still, BNP is an important biomarker used to help establish the diagnosis of congestive heart failure. The BNP hormone is produced by the heart and reflects how well the heart is functioning. Normally, only a small amount of BNP, less than 100 pg per milliliter, is found in the blood. However, when the heart is working harder than normal over a long period, the heart releases more of the substance in the blood level of BNP. The following provides various BNP levels and the cardiac status associated with these levels. BNP levels below 100 indicate no heart failure. BNP levels of 100 to 300 suggest heart failure may be present. BNP levels above 300 indicate mild heart failure. BNP levels above 600 indicate moderate heart failure, and BNP levels above 900 indicate severe heart failure. Chest radiograph. Bilateral fluffy opacities with a predominantly central position in the chest. Dilated arteries, left ventricular hypertrophy or cardiomegaly, curly A and B lines, bat wings or butterfly pattern, and pleural effusion. The radiographic associated with left heart failure are commonly described as follows. Cardiogenic pulmonary edema with mild left heart failure. There's pulmonary venous congestion with dilated pulmonary arteries. You can see a normal heart here and a heart with left heart failure. Notice how the left ventricular wall is thin and overstretched. Moderate left heart failure. There's cardiomegaly, engorgement of the pulmonary arteries. There's presence of curly A and B lines. When cardiomegaly is present, the heart is greater than half the diameter of the thorax in a posterior anterior chest radiograph. Notice here that the increased cardiothoracic ratio. Notice that there are curly B lines in the outer portion of the chest, and the vessels are dilated and even a small pleural effusion. Here is cardiomegaly with hilar prominence and pulmonary edema in congestive heart failure. Curly lines caused by pulmonary edema. Curly B lines are short horizontal lines at the lung peripherally. Curly A lines are lines radiating from the hyla, the oblique arrows. Curly A lines, curly B lines. Curly A lines represent deep interstitial edema that radiate out from the hilum into the central portions of the lungs. Curly A lines do not reach the pleura and are most prevalent in the middle and upper lung portion. Curly B lines are short, thin, horizontal lines of the interstitial edema, usually less than 1 centimeter in length, and extend inward from the pleural surface. They appear peripherally in contact with the pleura and are parallel to one another at right angles. Although they are seen in any lung region, they are most commonly seen in the lung base. Here you can see curly A lines in the apex, curly B lines in the base, and curly C lines in the center of the lungs. Moderate left heart failure. Because the X-ray densities primarily reflect alveolar filling and not early interstitial edema, by the time abnormal findings are encountered, the pathologic changes associated with pulmonary edema are usually advanced. Chest X-rays typically reveal dense, fluffy opacities that spread outward from hilar regions to peripheral borders of the lungs. Here you can see a bat wings or butterfly pattern that is typical in pulmonary edema. This example is very typical in that it is bilateral but not symmetrical. The shadowing is maximal in the central or perihilar portions of the lung, and the outer portions of the lung are relatively clear, causing that bat wing pattern. Severe heart failure. During this stage, the patient chest radiograph shows cardiomegaly, pulmonary artery engorgement, interstitial pulmonary edema, fluffy patchy infiltrates of pulmonary edema, often the bat's wing pattern that you just saw, and you may even see a small pleural effusion. In non-cardiogenic pulmonary edema, you may see a chest radiograph may show areas of fluffy densities that are usually more dense near the hilum. Infiltrates may be unilateral or bilateral. A pleural effusion is usually not present. And most important, the cardiac silhouette is not enlarged. Treatment for pulmonary edema is based on the cause, that is, whether it is non-cardiogenic or cardiogenic, and the severity. Non-cardiogenic pulmonary edema. The treatment for non-cardiogenic pulmonary edema is largely supportive, such as oxygen therapy, and aimed at making sure that the patient continues to breathe and oxygenate. You may use lung expansion therapy or oxygen protocols for these patients. Cardiogenic pulmonary edema. The therapeutic interventions used to address the patient's circulatory system has the following three main goals: reduction of pulmonary venous return, preload reduction, reduction of systemic vascular resistance, afterload reduction, and inotropic support. Cardiogenic pulmonary edema preload reducers include nitroglycerin in the form of nitrobrid, Minitra, or nitrostat, loop diuretics like Lasix, morphine to reduce pain, afterload reducers such as Vasotec or Nitroprusside. Shown is a picture of how Lasix works on the loops of Henle in the tubular lumen of the kidney. Cardiogenic pulmonary edema also uses positive inotropic agents like dobutamine for blood pressure, or dopamine, Levophed, and milorone. Dopamine is made naturally in the brain. It's called the happiness drug. Other arrhythmic agents, such as atropine for bradycardias and procainamide to treat tachycardias, and albumin. Now, you have to be careful with atropine because an atropine overdose can make you sweating, but increase your temperature, can make you confused, flushed, and dry out your secretions. So, a way to remember this is hot as a hare, mad as a hatter, red as a beet, and dry as a bone. What will you do as a respiratory therapist? Give oxygen as needed to keep sats %90 or better. Do lung expansion therapy as needed, and make sure the patient stays breathing. This may include the use of either a ventilator or non-invasive ventilatory therapy. This is the end of the lecture on pulmonary edema. Thank you for your time and attention today. Have a great day.